So I think obviously everyone has got their head in COVID-19 at the moment, and unfortunately the timing for Australia is that it's hitting us when the flu season will be sort of about to kick off as well. So this is just some thoughts about flu and what's ahead for the 2020 season. Try and cover some of the funded programs, a bit about the vaccines and age groups, what we know from last year's safety vaccine. And then just one comment, because I know Vanessa is going to talk more about COVID-19, but we have been asked about what to do with when you've got elderly with influenza and pneumococcal vaccines and the need for booster doses with those. Okay, so 2019 was a pretty bad year. We tend to do good year, bad year, so hopefully it'll be a good year from flu. I think a lot of what's happening with COVID might interrupt the flu transmission, which is potentially a good thing as well. So that's we'll wait and see with that one. In terms of the vaccine effectiveness against flu in last year, this is data from a surveillance system known as FluCan-Peds, and that's really a hospital-based surveillance system, including paediatric hospitals. And what we do around the country each year is collect data on hospitalised cases of flu, as well as controls, and we use the case control method to try and work out the vaccine effectiveness. And as you can see here, overall effectiveness was about 40%, and it's usually somewhere in that 40 to 70% mark. A little bit better in children, up to 60%, and it's traditionally not so good in the H3 space. You can see there that's lower and not so good in the elderly as well. So that's around about the estimates for last year's flu season of 40% this year. In fact, the FluCan-Peds system will actually be looking at collecting COVID cases as well. So hopefully we can inform on the clinical story of COVID cases as we go on. For this year, all vaccines in the 2020 season will be the quadrivalent flu vaccines. Those that are under age 6 months to less than 5 years can get annual free flu vaccines under the National Immunisation Program. Basically, you don't have to think too hard about the ages anymore. Everyone is getting a 0.5 ml dose. The 0.25 ml dose for young children won't be available. And in terms of those over the age of 65, we do prefer the high energy or high sort of adjuvanted formula vaccines, such as Fluad Quad. The adjuvant, it just gets a better immune response in the over 65s. So this is recommendations from the government and the eligibility. Recommendations are that over 6 months of age are strongly recommended. And as I mentioned, it's funded for 6 months to 5 years. Another important group to make sure that they get is for all Aboriginal and Torres Strait Islander people aged 6 months and over. Pregnant women, which I'll say a little bit more later on. You know that over 65 should get it. And then those that are 6 months of an age and over, particularly those over the age of 5 who have medical conditions such as, immune suppression, chronic diseases, they should get the flu vaccine. This is a table which is found on the ATAGI clinical advice statement. And you can see here that important things to take note of really are that the dose is 0.5 ml across the board there, depending on the brand. You can see there that in the over 65s, the two adjuvanted, there's Fluad Quad, and there's also the Afluria Quad. They're the ones that we should be using in the over 65s. The adjuvanted one, because it's got the word "ad" in it, that's the one that we preferred in the over 65s. Okay. So that's a table which you can have a look at later on when the flu vaccine starts to arrive in your rooms. In terms of the flu vaccine in pregnancy, you know a lot of this, but we certainly say that it's recommended in every pregnancy and at any stage during the pregnancy. Now we're giving the whooping cough vaccine to pregnant women as well. And so the question arises, can we give the flu vaccine and the DTP at the same time? And the answer to that one is yes. If you did get a flu vaccine in 2019, Say, for example, you got it around about, October, November last year when you were pregnant, you can give it again, the 2020 version this year while they are still pregnant. So you basically give it the 2020 version. For women who did get the flu vaccine before becoming pregnant, so for example, some women get the flu vaccine in April. They do then become pregnant in July of that year. We recommend that they do get another dose whilst they're pregnant. Now the question is, do you wait for the following year or do you give it that same year? The higher risk really is for the woman herself is the later stages of pregnancy. But I think the message here is that if you did get the vaccine before you became pregnant and you did become pregnant after that, then you can get the vaccine again that year. This just shows a little bit about how Australia compares to other countries in terms of our flu vaccine programs. We started off with Western Australia having a state-based program in 2008. In 2014, we had this program where it was mainly the Indigenous. 2018, states and territories were offering it to all kids aged 6 months to 5 years. In 2019, the same thing happened again. And this year, it's been listed on the National Immunisation Program. So no longer do states and territories need to fund that flu vaccine for 6 months to 5 years old as part of the national program. For the over 65s, as I think I've tried to tell you a couple of times, the Fluad Quad is recommended. It's just a better in terms of the, in 2018 and 2019, we were using the adjuvanted vaccine was a trivalent vaccine, so it's a single B strain. The Fluzone high dose, which we were using last year, the trivalent vaccine won't be supplied this year. So it really is just the Fluad Quad. And if someone says, look, I'm about to travel and I haven't got the Fluad Quad, can I get the old QIV? Then yes, you can. And so the question often arises with them is that they are getting it to the standard in April and they're about to travel. Should they get the adjuvanted vaccine later that year? The ATAGI advice is that revaccination is not required, but you can still do it if you really wanted to. But for most folk over 65s, if they've just had the standard QIV because they couldn't wait to get the adjuvanted one, then that's okay to give. The revaccination is not required, but it's probably not a bad idea to do it later that season. In terms of vaccination coverage, what do we know from the Australian Immunisation Register? And our team have looked at this and published it last year. We're not doing as good as we'd like in terms of the children. So we know from 2019 that around about 6.7 million Australians aged over 6 months got at least one dose of it. So that's about a quarter of the population on the air. The coverage estimates are probably a bit more reliable in children than older adults because clinicians and nurses are used to putting children's records on the air as well as the older adults, but they're not so good at putting those that are aged between 5 years to 50 years on the register as well. So in terms of the uptake, this is Indigenous versus others, 2017 to 2019. In kids aged 6 months to less than 5 years. And you can see that we've gone better than we were in 2017, but we're still only really about the 40% mark of kids getting it. Now this year, and remember that the vaccine was funded free for this age group by states and territories for the last couple of years. So even with a free vaccine, it's just not quite getting into the arms of these kids aged this year. Or in the previous couple of years, and hopefully we can do better. And it might be that people are more attuned to it this year because of the COVID story as well. This is the flu influenza uptake by a little bit more detail about the 6 months to the 5 year. And you can see here that 6 months to 1 year old are probably the highest group, and that's at 56%. But the older preschoolers, the 3 to 5 years, a little bit lower, about the 35% mark. So, you know, there's some improvement there as well. In terms of Indigenous kids, this is over the age of 6 months, and again, you can see over time from 2017 to 2019, we've had an increase every year. So quite pleasing results in the over 65s at 75% in 2019. In the 6 months to 5 years, it was only about the 40% mark. And then remember that the vaccine is again free for Indigenous Australians over the age of 6 months. So a little bit of room for improvement there as well. Overall, about 58% had a dose recorded. In terms of vaccination in pregnancy, might be a bit hard to see these slides, but this is data from Victoria, and you can see here that statewide the coverage was pretty good for flu in pregnant women at 67%, but not as good as pertussis at 82%. In terms of other places, Western Australia, the overall coverage was pretty good as well. It's around about 29% weren't vaccinated in 2019 and 15% weren't. So overall in Western Australia, about 56% of the women were getting the flu vaccine in pregnancy. Victoria in 2019 around about the 67% mark, and New South Wales a little bit lower at 45% from the register. This is coming off the perinatal registers. So again, some room for improvement in the pregnant women space. Often the question we get asked is when is the best time to get the flu vaccine? And ideally, as you know, the vaccine should be given before the onset of each flu season. So vaccine should be arriving. I think you may have already arrived in the ACT, but in the next couple of weeks as well. The best protection against flu is certainly for the first 3 to 4 months. And then therefore, after that, the vaccination effectiveness appears to wane. So I think ideally, the question is, do you give it now or do you wait? I think because of the COVID story, I think I would not be waiting. I think I'd get the vaccine in as you can as soon as it arrives, because we don't want people to have co-infections as well. So I think that's the message, particularly for pregnant women, particularly when kids are over the age of 6 months, and particularly those with chronic conditions. Now, if they do get it in April, and time will tell, we'll probably update the advice, but it's good to get it in now. And if they're going to travel to the Northern Hemisphere or so later in the year, then they might want to get a booster dose. But for now, once the vaccine arrives and you have capacity, which may be difficult given the distancing measures that are in place, try and get the vaccines in. So overall, a single vaccine is recommended. We do say, though, that those who are aged 6 months to less than 9 years who are getting the vaccine for the first time, they should get 2 doses at least 4 weeks apart. And those who have had a stem cell transplant or a solid organ transplant. And then again, the nice ATAGI line saying that 2 separate doses in the same season is not contraindicated, and that's as we talked about before, if there's travel later in the year or if there's a pregnancy which is spanning 2 flu seasons. So a couple of questions to sort of finish off with. One of the ones is about the egg allergy, because as you know, these flu vaccines are grown on the chick-based embryos. We've now given anaphylactic people to eggs. We've now given them the flu vaccine safely, and so therefore ruling allergy is no longer a contraindication. And in terms of latex allergies, flu vaccines used in Australia are now latex-free and are safe for use by people that have a latex allergy or a sensitivity. And then the other question is, does the flu vaccine always work? Well, the answer to that is no, and I've showed you the vaccine effectiveness, somewhere between 40 to 70%. But it probably, at a layman's terms, probably worth highlighting that having the vaccine pretty much reduces your chance of getting flu by around about a half. And the other thing it does, which is quite important, which we haven't not yet got for COVID, is to provide some community immunity so that we don't spread the flu round. Okay, in terms of the safety of the flu vaccine, we've got different ways to do it. One of the nice ways we do this is through a system called SmartVax. Some of you may be taking part in this. What happens is that GPs that sign on to this system, their patients who they've given a vaccine to will get an SMS a few days after the vaccine asking for any reactions. They then do a survey. That is responses are de-identified and it's published on the AusVac safety website. This is overall how the vaccine performed in 2019. Any adverse event, which is the total there, is around about the 6% mark across the different age groups. The common things that people are reporting are a bit of an injection site reaction, a little bit of a sore arm. You can see that the people needing to have medical attendance, which includes either phoning a GP or going to have to see a GP, was less than 1%. So quite a safe vaccine in that space. In terms of the distinction between the NIP vaccines and the flu vaccine, so that's kids that are getting an NIP vaccine and a flu vaccine. For example, they might be turning up at 12 months to get an MMR, a meningococcal, a 13-valent and a flu vaccine, i.e. 4 shots in one visit. You can see that the adverse event rate is not markedly different between those that got NIP only and those that got the combination vaccine. So I know parents often worry about getting flu vaccine along with their routine scheduled vaccines. I think the message for you guys in the provider land is that it is safe to give them if the parents want to have extra needles. I suppose the key points are the 12-month and the 18-month mark. It's important there that, you're getting 3 plus the flu is 4 needles, but the safety profile is pretty okay. 6 months and 4 years, you're only getting the 1 needle and the extra flu shot is pretty fine. So that's an important take-home message for you guys. In terms of pregnant women, there are about, just in the survey here, nearly 3,800 women who were surveyed. The actual adverse event rate was quite low at 5.5%, and only 0.5% require going to the GP. The types of things that they're showing are injection site reactions, some redness, tiredness, etc. So again, it's reassuring safety data and this is the 2019, so there's no reason why the 2020 version should be any different. Now, if you want to see how it's performing for 2020, the AusVac safety website will be updated weekly. And so you can see as soon as we start getting the vaccine into people's arms, we'll build up numbers very quickly. And so you'll be able to look at it real time. And it's often quite useful to show your worried parents or people who are getting a vaccine, look, to show here's some real-time data on how the 2020 vaccine is going, and you can just show them on the screen. There's a lot of resources available, and I'm sure you'll hear more about what's available in the ACT. Important websites include NCIS, and there's a Targi one on the immunisation health website as well. In terms of COVID-19, as you know, there isn't a vaccine yet against coronavirus. In the media, there's a little bit of thought about whether influenza pneumococcal will give you any protection, and the answer to that is no. I think particularly those who have chronic disease, you can get benefit from having the flu and the pneumococcal vaccine because you can just reduce the chances of having co-infection. So I think, again, the message is push that one out strongly. So that's it from me. I know it's been a bit of a rapid run through, but I'll stop now and let Vanessa talk to you more about what's happening in the ACT and then also some COVID story as well.
Thanks, everyone, and welcome. Tonight I want to talk to you about, predominantly about influenza, but there's certainly information about COVID-19 too, and please feel free to ask me questions about that tonight. So I want to talk today about the local epidemiology of the 2019 influenza season here in the ACT, talk a little bit about what our vaccine distribution looked like, talk about the ACT health immunisation schedule for this year, I'll remind you of reporting requirements for influenza vaccination, talk a little bit at this webinar about antiviral therapy for influenza, which I think is quite pertinent in the context of co-circulation of COVID-19. And then I'll talk about COVID-19, update you a little bit on epidemiology and testing criteria and some of the social distancing measures that are being implemented here and across the country to try and slow transmission of this disease. Okay, so really this graph shows you the number of flu notifications over a 6-year period, so from 2014 to 2019, and the 2019 epi curve is in the red here. And what this data tells us is it really mirrors the national data. And of course, you know, it is accepted that we don't receive all notifications of illness through our system. Someone has to present to a healthcare setting and then get tested and get a positive result to be notified to us. But you can see that certainly it was a long season. We all felt that. And it was a significant season. And the case numbers were definitely, well, they actually exceeded the numbers of our previous significant season, which, as Nick said, was 2017, which is in this dotted line here, although we didn't see the same kind of peak in a single week period as we did in 2019. So it was long and drawn out, and it was a challenging season for all of us. So it started about 8 to 10 weeks earlier than previous seasons, and it lasted longer. Okay, so what this pie chart is showing us is the notifications to ACT Health by type and subtype, and you can see that predominantly it was an influenza A season, although the vast majority of those were untyped. 76% in total were influenza A, and influenza B accounted for 23% of total notifications. So this graph really demonstrates the number of notifications that are broken down by week for 2019. You can see that the season started with I guess a mix of influenza A virus subtype H1N1, which was in the blue, and subtype H3N2. But after about week 25, the predominant circulating strain was the H3N2, and H1N1 didn't really come back into the picture until much later in the year, where we saw this little uptick in notifications, and that was consistent with importations from travellers who are returning from the Northern Hemisphere. Just a little word on our vaccine deliveries, and I think a shout out and congratulations to our vaccine management unit. These are the number of deliveries that were made in 2019, and what these units equate to is the total number that went out minus the number that came back in at the end of the year. And so that's the grand total, and we are assuming that that number of vaccines made it into arms, and that is certainly a record number for the ACT. I won't go through the groups again for whom the influenza vaccine is free for. In the ACT, it's the same as the national categories. I will say that we had a pilot of a pharmacy vaccination program for NIP-funded influenza vaccine for people aged 65 years and older, and that was successful, and that is being continued again in 2020. And vaccines obviously are also recommended for anyone 6 months and over. For those that don't make it into the funded categories, it's available on the private market through GPs, through early immunisation clinics for those. No, well, they're all funded, so we don't need to send them to there for private flu, but also to pharmacies for patients aged 16 years or older. So as Nick indicated, we expect the vaccines to arrive very shortly. Our anticipated date is the first week of April, and delivery of that base vaccine stock to GPs and pharmacies will commence. We're aiming to get out as much stock as we can to GPs, particularly those high throughput GPs, as much stock as your fridge capacity will allow, and that it is safe to deliver. And I think there has been, or will very shortly be, some communications to you about that. They can be used as soon as they're received. As Nick said, we would recommend starting to vaccinate in April and throughout all of the subsequent months, particularly as the flu will co-circulate with the coronavirus this year. Okay, so while you have date in stock, you can give it at any time, and you can always place additional orders of stock into the vaccine management unit using the sort of well-established processes that I'm sure you're all aware of, but they're also outlined on our ACT Health website. As you all know, we strongly encourage you to record your influenza vaccinations on the Australian Immunisation Register. This really gives us a very good indication of rates over time. As Nick said, we're pretty good in the under 5s and the over 65 years age group, but it is those middle years between 5 and 65 where we suspect probably more people are being vaccinated, but they're not being captured on the register. So we would really like to see that. Adverse event reporting forms are available on the website. As Nick said, it's really important that we continually monitor adverse events, and that's absolutely critical for national monitoring. We'd also like you to report any off-licence or inadvertent administration. And finally, the GP and influenza and the pneumococcal vaccine administration form. I understand the data burden on clinicians, but these are really important for us to monitor our coverage of high-risk groups when we can't necessarily tease that out from the AIR data. And it really helps us to tailor those messages to those groups that we don't suspect are getting, where we need to really increase vaccination coverage. So I guess I wanted to say a word about antiviral therapies, and I wanted to say that especially this winter when flu will be circulating at the same time as this new coronavirus. So treatment with some antivirals, the neuraminidase inhibitors, we know that may reduce the risk of viral shedding and disease transmission, and there's no more important year than this year when we need to be doing that. I know the evidence around the efficacy of antivirals in terms of hospitalisation and complications is a contested space, but certainly some studies have suggested that antiviral therapy reduces the severity and incidence of complications of flu, the length of stay in those that are hospitalised for influenza, including in older adults, as well as influenza-associated mortality. So the Australian Therapeutic Guidelines does recommend that when it's indicated, and I've put up the indications here on the slides, antiviral therapy should be initiated as soon as possible, as it's most likely, as you all know, to provide benefit when initiated within the first 48 hours of illness. And treatment should not be delayed if, in your clinical opinion, an individual has influenza while awaiting the results of diagnostic testing. Okay, so this is the end of my flu section. I didn't have any pretty slides like Nick does. He always shows me up with his slides, but we do have a lot of communication materials that are about to be launched on the website, and we will write to you all individually, as well as have a flu vaccination campaign launch so that you can see those, as well as providing you with a whole lot of resources that you can display and hand out to your patients. And as always, our immunisation inquiry line is available here and on our website, as well as our CDC surveillance line. We will be putting up regular influenza surveillance reports as we did last year. Okay, so COVID-19, I'm not going to go into the detail of the epidemiology globally, but I think, I think we're all pretty much aware from our reading and from the media that cases are widespread across many countries. So the darker colours represent an increased number of COVID cases per 100,000 population. Western Europe and USA are in particular experiencing rapid and significant increases in cases, in hospitalisations and in deaths. This EpiCurve is taken from the Department of Health Commonwealth website. They're now displaying an EpiCurve every day, as well as some demographic data on confirmed cases, which is really useful. And so you can see that cases are increasing very rapidly in Australia. I guess I would say that for the main, they are still largely associated with overseas travel or contacts of confirmed cases, or small clusters in congregate settings. But there is some localised community transmission happening in Queensland and New South Wales and Victoria. New South Wales, Vic and Queensland are contributing most cases. In the ACT, we have 39 confirmed cases, and we have, in addition to those confirmed cases, 2,780 people have returned a negative test. In those 39 cases, they've all had overseas travel, all an epidemiological link to other confirmed cases. So at this stage, we don't have any evidence of community transmission in the ACT, which is really good news. There have been some reports in the media, both, I guess, from local reports and national reports that we're not doing enough testing. Certainly in the ACT for about a week, last week I think it was, and the weeks are all blurring, we did need to tighten up testing to be within the suspect case definition, particularly for samples that were being sent to ACT pathology, because they were running very low of a range of materials that were needed to continue testing. Capital pathology didn't have the same issues, but it did mean that all patients that were being referred to the respiratory assessment clinics and through the EDs needed to fit that criteria. As of Sunday, this weekend gone by, we have secured some more laboratory resources for ACT Path, and we have extended our testing criteria to really broaden our ability to do some really good surveillance. So the criteria highlighted in red are new as of Sunday, and hopefully you all received that update. So while previously we had healthcare workers with recent onset of respiratory symptoms and fever, irrespective of travel history, that was there, we're now we're saying that healthcare workers who have fever or acute respiratory symptoms should be assessed on a case-by-case basis for testing. And that's not by CDC, that's by the testing clinician or healthcare worker. And then we have patients with acute respiratory illness or unexplained fever in other high-risk settings such as aged care facilities, residential care facilities, boarding schools, cruise ships, and correctional services should be included in that and will be updated, as well as patients with acute respiratory illness or fever presenting with reported links to settings where COVID-19 outbreaks have occurred. And that needs to be in discussion with us. So if you have a patient that says, I've been to a wedding in New South Wales 7 days ago and now I'm sick, then we need to talk to you about whether that person should be tested, because we may know about an outbreak associated with COVID-19 interstate. So what have Australian governments at all levels taken to slow transmission? You'll be aware that Australian borders closed as of 20th of March, 9 p.m. Only Australian citizens and permanent residents, as well as their immediate family members, can still enter Australia, and they must fulfil a mandatory 14-day self-quarantine on arrival or from the day of leaving the overseas country. And then on Sunday, again, I think it was into Monday, what we're calling stage 1 restrictions on social gatherings were introduced. Well, it did start with mass gatherings of 500 last Friday. By Sunday and Monday, that had extended to non-essential gatherings of more than 100 people inside, as well as closing a whole range of non-essential services that I'm pointing out here. Restrictions on visitors to aged care homes, that extends to correctional facilities here in the ACT. Residents being told to avoid all non-essential travel within Australia, and for all of us to take responsibility and play our part and our role in social distancing wherever possible, and practicing appropriate hand and respiratory hygiene. So why are we doing this? This is one modelling example, I guess, of, well, it's a schematic, it's not a real model, of what the epidemic curve would look like unmitigated. So that's without any public health measures or physical distancing measures to mitigate the impact. Obviously, it would be shorter than with mitigation, but it would be a huge peak and it would completely overwhelm our health system capacity. What we are aiming to do now is to flatten that peak so that we can protect our healthcare system, try and minimise the extent to which it breaks through this threshold of our capacity, and protect the most vulnerable. Most people that get this infection will still have a mild respiratory illness, but it's the elderly, those with chronic underlying conditions that are most at risk, and that make up the greatest proportion of the severe cases and deaths. So this is who we're trying to protect by undertaking these measures. So the social disruption will be for longer, but hopefully with less healthcare impact and saving lives, most importantly. In terms of wider health sector planning in the ACT, we're working through progressive actions that are being planned for home support for cases and contacts. This is going to be a long haul. It's going to have psychological impacts for people that are in quarantine, particularly for those that are already vulnerable and isolated. We are working each week. I'm meeting with an ACT primary care emergency response working group to work through primary care issues in particular, with representatives of RAC, GP, New South Wales ACT, the AMA, the Capital Health Network, and GP liaison officers across ACT Health, Calvary, Public Bruce and the Canberra Hospital. We have 3 assessment clinics that have been stood up in the ACT. You're probably all aware of them. The EPIC drive-through was the most recent to open probably on the weekend or last Friday, and they are seeing a huge load. And as we're working very carefully on how we maximise our hospital capacity, look at patient flow and alternate models of care to reduce the burden on our acute care sector. And part of the role of these RACs, as we call them, is to reduce that burden, particularly on EDs at this point of time. And this is including all private hospitals as well. So every hospital is participating in this. We're looking at ICU capacity here and within the region, and progressing a sector-wide response. We're focusing on at-risk groups. So 7:30 a.m. tomorrow, we're doing a webinar with aged care facility staff. But we're also looking, working very closely with Woononga Aboriginal Medical Service to ensure that they're ready to meet the health service needs of their clientele. And we are meeting with Correctional Services and Justice Health. And there is a large communications team, whole of government, that's been stood up to provide the best evidence in the most timely manner appropriate, so that we can inform our community and our healthcare providers of what they need to do at each step of the journey. I'm not going to talk about COVID-19 and management, A, because I'm not an expert, B, because there's still a lot of unknowns. But I thought I'd raise this issue because this is something that could be an issue in primary care. You might be aware that there have been anecdotal reports in the media that ibuprofen can result in more severe clinical outcomes in patients with COVID-19, and obviously those patients can have fever and may turn to ibuprofen to reduce that fever. The World Health Organization initially recommended that people with symptoms of COVID shouldn't take ibuprofen, but they've subsequently retracted that advice based on the evidence that's available to them and expert researchers. So they're not recommending against the use of ibuprofen, and the TGA has also undertaken a scientific review and cannot find any peer-reviewed scientific evidence to support that link. So I thought you might be interested in that. I think that is my last slide. Obviously, the Chief Health Officer Alerts page is where you go as clinicians for the most up-to-date clinical advice. But there's the Commonwealth Government website there too, which has a plethora of information, and we also have our public-facing advice for information for the public on all sorts of matters related to COVID-19. So thanks very much. I'm going to turn to my trusty assistant who's been collating your questions, and we have a good amount of time for questions. Okay, so I'm going to answer some questions that have been directed to me in terms of flu and the ACT. So which pharmacies do the 65 plus flu vaccination? That's a good question. We are going to have a list of those pharmacies. I understand that this year it's 50 plus pharmacies that will be taking part in that, but we will provide a list as we did so on our website as soon as we launch the vaccination campaign in the coming weeks, but it's a higher number than last year. And it's across all geographical regions in the ACT. So the next question was, in 2019, pharmacists in ACT could give vaccines independently, but practice nurses could not. Has this changed or can it be changed? Yes. So this question goes to the issue of nurse immuniser changes in our legislation. And I have to confess that I'm not up to date as to where that is, but I might get you to go and ask Carolyn, yeah, who might have a better answer for that one for you, because I think that is a very good point. And certainly ACT Health have been working to allow practice nurses to be nurse immunisers. I'm not across the latest on that. Can we legally have flu clinics outside of the practice? Where can I get info on this? I'm not really sure how to answer that question. And it may be that the person that asked that question may need to make contact with me directly. I think if you're talking about standalone flu clinics outside of your general practice, then we would, in ACT Health, would have to have a discussion with you to make sure that you're adequately set up to do that. But I think I need to talk to that person individually. I don't anticipate the government's not going to stand up vaccination clinics. We have a number of avenues by which community members can access flu vaccines, and we believe them to be adequate. So if you feel like you need to do something in addition to that, then we would like you to contact us to discuss that with us. Nick, great. Let's get some questions for Nick. Okay. So in terms of the nurse immuniser question, I understand the response that I've got scribbled here is that legislation will be in place by the middle of the year. And I know we have a working group with nursing representatives on it and all the key stakeholders, and more information will be forthcoming as soon as that legislation is through. But the Minister has made that commitment, and we are progressing.
Waiting on announcement. Waiting on announcement.
Okay. So, Nick, I'm going to throw a few clinical questions your way. I'm not sure if you can answer them, but we'll do our best. So one of the questions relates to what is the increased risk of acute myocardial infarction during or following influenza disease? I suggest that would be.
Yeah, so look, we don't have a brilliant answer to that. Raina McIntyre at New South Wales University has looked into it, and she certainly, I mean, in people that have recently, she looked at a study in 2008 to 2012, and in people that had recently had heart attacks, she found that in about 12% of them that actually had swabs taken at the time, they found flu. Which wasn't sort of clinically indicated. So certainly flu we think can precipitate or lead to some coronary artery insufficiency and heart disease, or heart attacks rather. But, you know, the data on the absolute amount, I can't answer you that, but certainly it is there, and I think that's why they're considered a risk group and would be a benefit from the flu vaccine, particularly in that 50 to 64-year-old age group. So, you know, it's free for the over 65s, but those 50 to 64 with underlying coronary artery disease, flu can be a contributor to an attack, ischemic heart disease attack. So I think the vaccine is particularly useful for them.
Nick, can you update us on any data from the Northern Hemisphere regarding vaccine effectiveness, noting that I guess the makeup of their vaccine may differ from ours in the Southern Hemisphere?
Yeah, it's still around about that 40 to 70% mark. I can't give you the exact figures from the US. Again, the H3 strain, less than that, 30%. In some places, it was even sort of down around the 10% mark. So H3 is not our best part of the vaccine, but H1 is up there. So it really depends on what sort of strains we get circulating. And as you mentioned, there's different strains have gone into this 2021, but it's a ballpark of that 40 to 70%.
Okay, thank you. Should 65 and over, people 65 and over and immunocompromised patients receive 2 doses as well of the vaccine?
It is complex, and we're looking at or trying to simplify within the handbook. But if you're over 65 and you've just recently got one of those diseases that puts you at high risk, then, and you've already had, say, the Pneumovax, then the recommendation is that you should get a 13-valent pneumococcal vaccine, so the Prevnar 13. So that's the one we use for kids. You should get that one at least 12 months after your 23 Pneumovax. And then at least 5 years after the Prevnar 13, you should get a Pneumovax 23. And then you should get a further Pneumovax 23 5 years after that, second Pneumovax 23. So it is very confusing, but I think what's important to take home is the handbook spells it out quite nicely in the pneumococcal section. But if you're over 65 and you've got one of these new onset diseases, get a 13 valent. So get the Prevnar 13, get the kid one in, and then about 5 years later, get a Pneumovax 23.
Thanks, Nick. And what about...
I hope that sort of answers.
Yeah, no, it's great. It answers a couple of other questions, but I think that was specifically related to influenza vaccine. So 65 years and over and immunocompromised, should they receive 2 doses of flu vaccine?
Yeah, look, definitely over 65, they should get the single adjuvanted vaccine. At the moment, we're not recommending revaccination for those who are immune suppressed. Now, would it hurt them? Probably not, but it's not part of the recommendation.
And it'd be interesting to hear what you say about this. If someone is self-isolating because they have COVID-19, when would it be the best time to give them flu vaccination if they haven't had it before then?
So they definitely have to complete their isolation period. They can't go out of the house until they've done their time, so to speak, whether that's 14 days or what. In general rules, we don't like to give people who have a fever a vaccine, mainly because the side effects can be confused with the disease, and fever can be one of the side effects. But I think so. So wait till your isolation period is up and have no fever, then you can get the vaccine. If you've still got a bit of a cough and runny nose, that's fine, you can get the vaccine. But if you've got a fever, I think it's better to wait till the fever has disappeared.
Yeah, I would concur with that. Would you have an opinion, Nick, noting you're a paediatrician, but and I'm not sure how much you use antivirals, but is Tamiflu the preferred drug and is it on the PBS? Would you know that?
I know in our hospital, Tamiflu is underutilised for their children. It has to go to the local drug committee for approval. I noted that in other states, such as Victoria and particularly in Royal Children's, it's much used more liberally. I don't think it's on the PBS there, so we could check that. But it's really the only one that is got some effectiveness.
Okay, we might do an FAQ on antivirals and influenza actually for the website. Do you know, Nick, if people with a BMI over 30 are eligible for government-funded vaccines?
That's a good question. I don't know the answer to that one. I mean, again, clinically it's recommended, but whether they fit under the NIP listing, you guys might know that one.
Yeah, we should know that. Carolyn would know that too. If obesity, I think obesity is a category, but we will just check. No, it's not, she tells me. She's in the wings. Sorry, our immunisation manager's in the wings. Apparently not. It's not funded.
Yeah, clinically useful, but then it becomes the cost to the person.
Yeah, exactly. Okay. I think I've answered my flu questions. I'm wondering, I'm up to COVID questions for me. So let's see. Oh, one more for Nick while you're on a roll, Nick. Can someone with chronic disease under 65 years get Pneumovax? Are they funded for Pneumovax?
Yes, I think they are. Yes, they can. Yep.
It is a really complicated schedule, and I concur with Nick. Looking in the handbook and photocopying the table is a very good idea.
And just to say, we're also hoping to try and simplify that because there's potentially some changes that will be coming in the middle of the year about that. So hopefully the categories will be, simpler to follow because it is very confusing, category A and B diseases, etc. And so hopefully that will be simplified. But for right now, the handbook's the best we've got.
Yeah. Okay. So how should we, so this is COVID-19 questions. I'll have a go at these and Nick chime in if you would like to. How should we assess whether a patient has a reported link to settings where COVID-19 outbreaks have occurred? It's not always feasible to call CDC for every patient who travelled interstate. I agree, that's quite tricky at this stage, but what we're hearing anyway from GPs and also from members of the public is that they are telling healthcare providers that they're aware of cases at a wedding that they attended in New South Wales or a religious service or another gathering And it's at that point that we need to hear from you. I know that's difficult, and it doesn't need to be for everyone that travelled interstate, because that's not the intention of that criteria. There isn't widespread community transmission in any jurisdiction. So really it's links to those clusters and outbreaks that are either in the media, and a patient may have picked up on that and hadn't been contacted, or through a series of Chinese whispers they have heard that they may be linked. We have that information. It's not information that we want to make publicly available necessarily, because it's evolving every minute and every day, but it's for those patients that we do ask you to call us. Do residents of uni accommodation count as high-risk settings for testing criteria? They do. If they're in the kind of typical, I mean, it depends on how boarding house they are. So if they are in single rooms and they have shared communal and eating areas and shared bathrooms, then yes, they're in a high-risk setting. If they're living in university accommodation where they have their own apartments, their own kitchen, their own bathrooms, that's less of a risk. So they do apply in the kind of dormitory style setting, as do military barracks would fit into that category as well. Need more clarification on a case-by-case basis for testing healthcare workers. There isn't a lot more clarification I can give you. I ask you to use your clinical judgment. You are doing that, we know that. I know that there is testing outside of the testing criteria by GPs, and that is fine. It's not, I mean, we weren't coping in ACT pathology. I'd preference you sending it to capital pathology if you're going to go outside the criteria. But I do ask you to use your clinical judgment, and I ask you to do that in that context as well. Are there restrictions on health retreats? I'd love to go on a health retreat. I wonder if that is a gathering of healthcare professionals. Yes, there are. Really, essential service staff should not be gathering in any number really at the moment for conferences, workshops, meetings, because of the risk of COVID-19 circulating and potentially taking out essential clinical workforce. If it's health retreats in terms of spas for the community or that kind of yoga retreat, certainly here in the ACT, you know, we've been told not to travel interstate, or non-essential travel should cease. If they were to be undertaken in the ACT, it would have to fit the criteria of the parameters around social distancing, one person per 4 square metres, all of those parameters. We would suggest they should not go ahead. But I'm not sure if that's a government decree, but I would suggest they shouldn't. How do we know when there is no community transmission when our testing has been limited to travel and case contacts? It's not okay to use healthcare workers as a benchmark for this, as the Minister said. Okay, so our testing has not been limited to travel and case contacts. We know that actually most testing up until probably 2 weeks ago was actually outside the case definition. So I don't accept that. We did have, for that 1 week period when ACT pathology was very stretched, we did try and we basically through ACT pathology couldn't necessarily test all those that were outside the case definition. As I said, that was not the case with capital pathology. When I did the numbers yesterday, and I haven't done them today, we have about a 1% test positivity rate. We in the ACT and in Australia, per capita, are one of the leaders in the world in our testing. So I don't accept that. Is it okay to jog and cycle outdoors? Yes, it is, as long as you're not doing it in large packs where you're very close together to one another and you're not distancing by 1.5 metres. It is absolutely okay and worthwhile to get outside and do some exercise, both for your physical and mental health benefit. It is just being mindful of all of the social distancing measures that have been announced. Did ACT Health recommend pupil-free days? How does your stance compare to the Federal Chief Minister Officer in regard to school closures? That's not an answer, a question I can answer. I do not sit on the AHPPC, which the Chief Medical Officer does, and so I can't. ACT Health did not make that recommendation. That was a national recommendation. The CMO made a range of recommendations across a range of social distancing measures, and then some jurisdictions, including New South Wales, ACT, and I believe Victoria, went further in terms of recommending that where possible, where students didn't need to be in school, that they do that. And in the ACT, the pupil-free days leading up to the Easter holidays is so that the Education Directorate and all the schools can gear up to do online learning. So that was not an ACT Health recommendation. How many ventilators are available in Australia in the ACT? That's not something I actually know. Not sure whether it's really helpful to know. What's helpful to know is that we, as well as all jurisdictions, are looking at all of their health sector capability and resourcing that they need to meet the demands of this, and they're modelling based on worst case scenarios. So all of that's being done, and it's more in the health and hospital sector than in public health. But as I said, I don't think that helps us because we don't know how many patients are going to need ventilators at this point of time. We are planning for the worst case scenario and hoping for the best. What is the appropriate PPE in GP at the in GP practices at the moment? Should we be wearing PPE for all patients, not just COVID-19 patients? I don't believe you should be wearing PPE for all patients. I mean, I guess I would suggest that where your patients, and I think a lot of your practices are doing this, are triaged either at the door, at your front desk, and they have respiratory symptoms, then giving them a mask, the sick patient a mask, is a really good idea. And if they're deemed a high risk for COVID-19, either taking them through to a single room, if that's available to you, asking them to wait outside, or cohorting them in an area of your waiting room that can be 1.5 to 2 metres away from other patients. In terms of who you should wear PPE for, well, I think it's important to follow national infection control guidelines. Droplet recommendations are recommended for routine care of patients for things like influenza and obviously for COVID-19. So I think for people with respiratory symptoms, they should be given a mask. And then we have specific recommendations about when clinicians should be wearing PPE, particularly in relation to COVID-19, but they exist for influenza too if you are testing patients. Most people, including healthcare workers, are getting flu vaccine in early to mid-April. Coverage will wane by July to August, usually peak season. How can we manage this? I wonder, Nick, if you just want to reiterate the ATAGI view on waning immunisation and what that really means in terms of population coverage and immunity.
Yeah, I think ATAGI feels that I mean, it's hard to predict it ahead of the season, but I think ATAGI feels that a routine second dose is not recommended. So, you know, last year people were saying should we hold off for the flu vaccine because of the waning story. And as you saw in the graph that Vanessa showed, flu came early, and so we were caught a bit hopping there. So I think once it's available, get it in, particularly now that there's COVID around. And I suppose over time we'll monitor the flu season and there might be a change to advice, but at the moment it's just, ATAGI says the single dose and revaccination is not routinely recommended.
Thanks, Nick. Should we wear PPE during delivery of childhood immunisations, because that's close contact with child and parent? I would say no. I guess as Nick indicated, usually, and most healthcare providers we across this, we don't recommend immunising children if they have an acute respiratory illness, particularly if they have a fever. But otherwise, well, children, I would definitely not recommend wearing PPE. And I guess the story with children, though this is not the reason I wouldn't recommend wearing PPE, I don't think it's needed internationally, is they don't seem to be as significant a driver of transmission as they are with influenza. So they don't seem to present a higher risk of transmission to each other and others, as is the case with influenza. When will flu vaccine be available to ACT staff? That's a good question. Yeah, you could check with Carolyn. So ACT staff generally get access their flu vaccination through Canberra Health Services Occupational Medicines Unit. I myself have not been notified that. Traditionally, that has been through the weeks of April. It starts, but it's available right through the season. It's being confirmed that it'll be early to mid-April. So it's really the same time as the rest of the community, and we expect to have those vaccine deliveries very soon. Do reception staff need PPE? We do not believe reception staff need PPE. As I said, the most important thing is to give a surgical mask to patients who present with significant respiratory symptoms, because that's going to prevent transmission of droplets from them to others. Reception staff typically have short periods of interaction with patients. If they're sick, they need to have a mask on. Generally, I would recommend in your practices that we can ensure that 1.5 metre social distancing between your staff and patients, but I would absolutely not recommend such a precious resource as surgical masks to be on staff that are not providing direct clinical care over a period of time, such as in a GP consult. So no, I wouldn't recommend that. Okay, Nick, I don't know if you've looked at how COVID-19 particularly affects children, or would you like me to speak to that?
No, look, I think fortunately kids do pretty well. So we know that in Italy up till date there have been no deaths in anyone under 19. There is much milder disease in the school child, and the infants are a little bit more risk than older kids, but certainly the percentage ending up in hospital is low, and the death rate is even lower, probably 0.05% or something like that. So it's quite reassuring that children are not affected by this. We don't understand the reason for that. It could be something to do with the ACE receptor in the lung being more well developed as you get older, and that potentially meaning more severe disease. But so kids less affected. It seems to be also from the transmission studies that we've done in the school spaces that they don't transmit it as much as they do with flu. So that, weighs into the argument about schools, etc. But and closures. But it's good news for kids. Is it the bottom line?
Yeah, I don't think I have anything further to add. I agree, it is good news. I wonder if you have an opinion on this, Nick, otherwise I'll try and tackle it. How safe is it to do spirometry and peak flows, I guess, in practices due to the sort of risk of COVID-19 in the community? It's an infection control issue, really, isn't it? Presumably, you wouldn't be doing that on someone with acute respiratory infection, but I'm not sure if you've got anything to add.
Look, it is an issue because it's unlike measles. It's not an aerosol; it's respiratory droplets. So, and the droplets we know can hang around on surfaces. So, it is a bit of a tricky thing. I suppose you could suggest that it's done outside. Would be one potential. Take them outside and go upwind from them. Would be one. It's a bit hard to do that with full, respiratory function testing in a lab. But for the general spirometry, it's probably I'd suggest an outdoor event, and think about whether you really need to do it. Is it going to change the clinical management? Would be my other comment at that particular time.
Yeah. And I will check with our infection control manager tomorrow just to see if she has anything to add and add it to the FAQs if that would be of interest. Thanks, Nick. Can we please, I'm going to throw this one to you too, it's about the pneumococcal vaccine eligibility. Can we please clarify the vaccine eligibility? There are no private vaccines available in the ACT, so we need to know who is eligible for use of ACT government supply. So that's possibly more for me, actually. I think we need there's obviously a lot of interest in this, and I actually need to seek further advice on that and further clarity on pneumococcal vaccine eligibility, unless it's just being handed to me now. What a team. Okay. So from the 1st of April 2019, so 15 to 49 years of age, Aboriginal and Torres Strait Islander people with medical risk factors, and they're outlined in the Australian Immunisation Handbook. Pneumovax 23 is funded for that group. 50 years and over, Aboriginal and Torres Strait Islander people, Pneumovax 23 is funded and is funded for those 65, all people 65 years and over. I hope that helped with that question.
Yeah, so I might have confused people earlier when I talked about it being funded for the under 65s with at-risk conditions. That's really only for the Aboriginal and Torres Strait Islander population. So that's probably my contribution to the confusion there. I'm sorry.
No, it's good to clarify. That's fine. We might go for about 5 more minutes. How can we encourage parents to proceed with routine immunisations? Parents are cancelling due to fears of COVID-19. Do you want to take that on first, Nick, and I can come in after you?
It's a tricky one. I think, if the surgery, I suppose the parents would be reassured that the surgery is screening potential patients, and therefore there shouldn't be any COVID, I suppose it's a hard one to answer in practice, but if the parents can be reassured that the surgery is trying to screen people, that they've got a setup where COVID people go into one of those fever clinics rather than going to the GP, that might help reassure folk. I think it is going to be a timeliness issue, like you say. People will probably decide to defer vaccination until things settle down a little bit. That's an issue for things like measles, etc. But for most of the infant one, We know that one thing you could say to the kids is, the parents of the kids, is that kids aren't that severely affected. We're doing our utmost to stop COVID coming into our particular surgery clinic, and that we won't try and unnecessarily expose you. But I haven't got a brilliant answer, I'm afraid.
No, it is a hard one. I think, I guess the good news in terms of the patients, some of the cases that we've had confirmed, these are through the respiratory assessment clinics, but there's no reason why it wouldn't be different in general practice when all these same measures are being taken, that we haven't had to do any contact tracing of patients in the waiting room or clinicians, because they're all following the advice around, giving the patient a mask, separating them out from other non-respiratory patients, as I might say, and using the appropriate PPE when taking respiratory specimens. So, to me, that suggests that, this is, and these are in walk-in centres where they are, seeing other business as usual patients. They're not all COVID-19. So people are, I think if we follow the right precautions, your practices are safe places to come. And people just need to see that you're doing that. We need to reiterate that from ACT Health Directorate, how closely that we are working with our GP clinicians, and reiterate the importance of routine immunisations and preventative care. The extent to which that can be done by telehealth for those in the age groups for which there is a rebate, let's do that, but that's not for the younger kids that receive vaccinations. They need to present in person. But to date, we have not contact traced a clinical waiting room. Anything more?
Two more questions.
Okay, we're going to take two more questions, and then we're going to call it a day. Okay, this will be an easy one for you, Nick. What should we do for patients who are under 9 years of age but missed their second dose last year?
So for them, just carry on, give them the one dose this year. So they don't need 2 doses this year. So they didn't quite get what they were supposed to get last year, but for this year, just give them the one dose. I hope that makes sense.
It does. Yeah, it does. Yeah, that's what we would say here at ACT Health as well. And it's another clinical one to end on, and I don't know the answer to this. But any evidence of people taking ACE inhibitors or angiotensin receptor blockers having increased risk of contracting COVID-19. I haven't seen evidence for that, but it doesn't mean that's the case. I'm not sure, Nick, whether you can answer that one.
No, not definitively. It's a slightly different receptor that the ACE inhibitor works on compared to the lung ACE receptor. But I think, if you're using your ACE inhibitor, which is well controlled your heart disease, then I think there's nothing to say at the moment to stop that, as far as I'm aware of. But maybe I know that they are looking at that particular question because there was an interest in whether an ACE inhibitors could be used for therapy. And I don't think it's been, in fact, I think it probably showed that they weren't very useful. So I'm sort of not answering the question because it's a new space, but it's something that's being actively looked at and was actively looked at in China.
Right, okay.
As well.
And just because there is one outstanding question after those two, we'll finish on this one. Is there evidence of cross-immunity with SARS or other coronaviruses to COVID-19? Again, I'm not aware of that. I guess with SARS, the issue would be that there wouldn't be a lot of immunity to that particular coronavirus here in Australia. I don't know to the extent that that's been looked at in China and other countries that suffered significant outbreaks with SARS. So while I can't definitively answer that, I don't think that's going to be of great assistance to us in Australia. Nick, would you have anything to add to that?
No, I need to echo what you said, that we didn't have a SARS in any degree to give us any population immunity. So they're probably, I don't know the degree of cross protection, but it's...
Yeah, but I think the bottom line is we would likely not have a lot of population immunity to that. Okay, I think we'll call this to an end. Thanks so much. Thanks everyone for joining us.
And stay well. You're doing a great job, GPs out there. So keep up the hard work. But it's much appreciated by the population, I'm sure.
Absolutely, I'd echo that. You're doing a fantastic job. Thank you for your goodwill, and thank you for staying late tonight to watch this. I hope it's been of some assistance. Thank you, and good night.